Good evening, everybody, and welcome to the Saturday series event, Broken Smiles, Revolutionising Healthcare. Before we start, some housekeeping, as they say. Please may I ask you to submit your questions via the Q&A feature. This evening will be recorded and will be available in the next number of weeks on the Saturday series website. So let's get started. I imagine that many of you will be wondering about broken smiles. Is it about teeth? Is it about smiles? And what the dickens does it have to do with revolutionising healthcare? What can we learn from teeth and smiles? I would like to suggest to you that broken smiles reflect the broken society in which we live. After all, according to Alston's Human Rights Watch report of 2019, we live in a society in the UK where 14 million people live in poverty, where 4 million people in full-time employment live in poverty, and where Alston predicted that 40% of children by 2020 would be living in poverty. In England, 1.63 million children are entitled to free school meals. To quote Winnicott from 1961, at the root of the antisocial tendency, there is always deprivation. And Camus's book, The Plague, he tells us, the plague brings the hidden truth of a corrupt society to the surface. And so now we are experiencing the whirlwind of the COVID-19 pandemic, where we have seen the effects of the austerity policies of successive Westminster governments. People from the poorest areas in our society have experienced the full force of COVID-19. The same social determinants implicated in the social gradient of heart disease, diabetes, tooth decay, and so forth are in operation now. Those who have contracted C19, those who have long COVID, and those who have died are those who have experienced the worst effects of austerity and poverty. Michael Marmot calls for change, and if I may paraphrase his words, we need to build back a fairer society. So how may dental health assist us in understanding our broken society, the inequalities we see, and the exclusion people experience? How can we revolutionise what healthcare means in its widest sense to build back better? This is what this evening is about. For you to hear first from our panel of experts as they present their work and their in-depth knowledge of how we may fix broken smiles to build a fairer society. And our speakers this evening are Matt Mayock from the School of Social Work and Education, University of Dundee, Andrea Rodriguez, social psychologist from the School of Dentistry, University of Dundee, Niall McGoldrick, from University of Dundee, the Dental School, Dental Public Health and NHS Fife. And last but certainly not least, Derek Holliday from Homeless Network Scotland and Strathclyde University. We look forward to answering your questions after their presentations. So please remember to submit your questions via the Q&A feature. Now it's over to you, Matt.
Thank you so much, Ruth, and thank you for the invitation to take part in this event. So my name is Matt Maycock. I'm an anthropologist by training. For the last 7 or 8 years, I've been doing research in and around Scottish prisons. So that was initially during a postdoc at Glasgow, and then I actually worked doing research within the prison system itself, doing a range of kind of different projects, a lot of which looking at kind of staff training and culture, but also issues relating to gender, transgender people in prison, those sorts of issues. And then more recently, I've joined Dundee, and again, I'm kind of doing a range of research relating to prisons. And I just wanted to start off my 5 minutes, which will fly by, I'm sure, by just highlighting a couple of really interesting reports in this sort of field. So the World Health Organization in 2014 published what is a really important kind of a landmark report on prison and health. It's widely available online. I'd highly recommend you have a look if you're interested in this area, just to look at the kind of wider policy context. And and as Ruth kind of mentioned, within prisons, there are some of the most disenfranchised and marginalized people anywhere. Dostoevsky said, you can find out how civilized a society is by looking in its prisons. And I think there's some really interesting things happening in Scottish prisons at the moment. So there's aspects of hope and opportunity. And I'm kind of referencing, there's a criminologist at Cambridge, Alison Liebling, who wrote a really interesting paper looking at the extent to which hope is available within prisons or possible as a, not just as a concept, but also is kind of broader possibilities. Like, what do prisons represent? They house some of our most vulnerable people, yet are they places within which there are opportunities to engage with people that you might not be able to reach in the community, or are they places where there's more harm done than hope possible? So they're complicated places, and I just wanted to also pick up on, I guess I'm going to refer more to kind of the Scottish context. So there was a really important report in 2005 by Roger Houchen, who for the first time really systematically linked deprivation to imprisonment. So this report is used quite a lot in these sorts of conversations, and just to kind of look at some of the poorest bits of Scotland are overrepresented within the prison system. So there's something going on within prisons and around prisons in relation to deprivation, poverty, which I think needs to be unpacked and thought about really carefully. More recently, kind of re-engaging with Houchen's original sort of analysis of linking deprivation with imprisonment. Ben Matthews has done some really interesting work at Edinburgh that's kind of refreshed that and actually looked at aspects of gentrification. So the links between certain areas and being in prison aren't necessarily what they used to be. So areas change and evolve and become gentrified or not, and that has implications for the ways in which crime and justice work in those places. So just to kind of pick up really again about the opportunities, I was thinking about these 5 minutes and how I could best use them. I was thinking about some research I did when I was at Glasgow, mainly in Perth prison, but also in Kilmarnock, and it was around people in custody getting the most out of their time within prison. So a lot of the work I was doing was in and around prison gyms. So a lot of us might use gyms frequently. Obviously they're closed at the moment, they'll be open at the end of the month. It was really interesting interviewing and getting to know a group of people in prison around gym use. These are people who hadn't used gyms in the community. They weren't available to them. They were maybe too expensive. But in prison, this was the first time that they were able to kind of go into these spaces and perhaps find ways to kind of get fitter in new ways, which was really surprising, but a really interesting thing to kind of emerge from a piece of that research. But then alongside these opportunities, and there definitely are some there in terms of education and health, but there are major challenges within the system. So to do research within prisons is challenging, to get access is sometimes challenging, to do research ethically can be very challenging in terms of issues of consent and informed consent in the research process. Just wanted to finish up on some more recent research that I've been doing, and I've got a few papers out on this at the moment, is when the lockdown came in wider society, that meant particular things within prison settings. So all research was pulled. So I ended up writing to a lot of prisoners just to find out what was going on in prisons through the COVID pandemic. And the data I've got is really quite bleak. So the idea that we can all understand what it's like to be in prison because of lockdown, I don't think really holds. It was to be locked in a cell for 23 hours a day, and that's where you eat, sleep, exercise, everything. I don't think any of us can quite understand how difficult that is. So that's my 5 minutes, and I will pass back to Ruth. Thank you. Looking forward to some questions later.
Matt, thank you very much for your very interesting 10 minutes. And I would like to ask Andrea Rodriguez to talk. Thank you.
Okay, thank you, Ruth. Good evening, everyone. It's a pleasure to be here in this important conversation. I'm working at School of Dentistry in a program to promote oral health and health equity for people experiencing homelessness. Before I became an academic, I used to work in third sector organizations as a frontline staff, a community worker, in social projects led by NGOs in Rio de Janeiro, Brazil. So from this perspective of working at university, but having this another identity in the past, I could see when Brute was talking about poverty, inequalities, broken society, I could see clear links with homelessness, because we know that poverty and homelessness, they are very well connected, and the role of university to address issues, sensitive issues, complex issues in society, I think should be in the way that society should perceive university as part of our community. So we should work not disconnected or detached from those working in third sector organizations, local authorities, health boards. We need to create more and more opportunities to produce partnerships, joint work strategies to address issues that we all want to address. So the way I choose to address poverty, inequalities, social justice is through research. I truly believe in the power of research, participatory research, to implement social change. So in my view, this type of research, we involve people from the communities, people that are living the problems that we want to find solutions. They should be involved in the research teams. They should be listen. We need to learn from them if you want to impact on their lives. So this type of research, the way I work, it's a very participative way. So I'm focusing my research currently with young people experience homelessness. So they are involved in a current project to co-design educational materials to help practitioners from health and social care organizations to approach to them and to discuss health promotion with them. Collaborative work, it's another key word for us, key element for us. The direct contact with policymakers, it's another important part of our work. We need to create direct channels of communication with those who are producing reports and legislation to address the issues we want to address. So we could involve young people in consultations through a knowledge exchange program we developed recently, that we could gather their views about service provision and professional approach, and their views, their findings were added to 2 Scottish reports on youth homelessness pathway prevention of youth homelessness. So this is the way that we believe should be the way to really reduce and address health inequalities and empower people and communities. And when I say empowerment of people and communities, I'm not saying that we are giving power to them. I don't believe in this. I'm just saying that we as university, we need to create more opportunities for people with a living experience to raise their voice, to reflect on issues that are affecting their lives, feeling safe and more comfortable to participate in process of production of knowledge and policy design. Just to end my talk, I want to say that I truly believe also in the power of public engagement to co-create a type of knowledge that should be collective, diverse, and inclusive. Collective because the production of knowledge is not something that belongs to academics, belongs to university. We all need to produce knowledge together. Diverse because we need to involve different sectors, different people in this process of learning and change. and inclusive, because the way we are going to include these people should be based on their own terms and not in our terms, and not in our way of communicating. So we need to leave our comfort zones as academics, and we need to go where they are and listen to them, learn from them. If you want to build a trust relationship in this process and to reduce poverty and health inequalities. Thank you.
Andrea, thank you very much for explanation of your work and how this links into promoting oral health, dental health, and helping people. So Niall McGoldrick, would you like to come next, please?
Great, thank you, Ruth. And thanks so much, Matt and Andrea, for sharing your thoughts and some great examples of work that you're doing. So my name is Niall McGoldrick. I'm a specialty registrar in dental public health for 50% of my time with the NHS, and the other 50% I'm based at the University of Dundee in the School of Dentistry. And it's really there where I've been exposed to some of the work that Andrea has talked about and the co-design and involvement of patients and the public in trying to tackle some of the healthcare problems that we have. Because I really believe that if we want people to really benefit from healthcare or health promotion activity, then we need to include them in production and design in a meaningful way. And I think if we really are to revolutionise healthcare, and in particular oral healthcare, then we must go much further than we have in the past, and especially in mainstream healthcare development within the NHS. Beyond having one or two patients as members of the public on large panels that are heavily weighted towards professionals, or asking patients in public what they think once we've opened a service or produced a health promotion intervention. So it's about doing less to people and doing more with them. And I think, again, like Andrea and Matt I've spoken about, we must understand the world from the point of view of the people we're trying to reach or help. So we must include them as equal partners as we redesign or begin to design something new. And I think this fits really well with something we all know about, or a lot of us will know about, is evidence-based practice, evidence-based medicine, evidence-based dentistry. There are three parts to that, as we know that we act on the best available evidence to us. We use our clinical expertise of the treating clinician or the public health practitioner, and patient values and preferences. But as my training has gone on, I have come to the realization that patient values and preferences need that equal footing. And it's for too long that the patient's values and preferences have not been an equal player at the table. And that's not something overnight that came to me as a clinician, especially with the culture of doctor knows best, or in my case, dentist knows best. And at this point, I just want to share an example of some of the work that I've been involved in recently with the Scottish Drugs Forum and colleagues in the School of Humanities and through my NHS role. And it's focused on the co-production and co-design of health promotion comics that are focused on oral health. And I'll talk about the aim of them in just a moment. But what the evidence base told us, or the available evidence base, was that people who have lived experience of drugs and alcohol experience poor oral health. And we had some ideas of how we might approach that. We had some resources available. And my colleague, Professor Freeman, who's leading this session, had begun to gather key stakeholders, bring key stakeholders together to set the foundations for the project. And just being clear about the aim was to co-produce and co-design a series of oral health promotion comics for people who have lived experience of drugs and alcohol. So how did we do it? Well, before we even thought about the content, we needed to know more about what would be useful for our target audience. And this is where the Scottish Drugs Forum came in with their group of peer researchers who all have lived experience and are now involved actively in research. We had a series of workshops where the peer researchers were equal partners with our artists, designers, myself as the healthcare professional. And most of the workshops, I have to say, were weighted towards the peer researchers, in that there were more of them there than there were of artists and healthcare professionals. And Aileen, if you could share the slides just now, this is just an example of some of the content that we've managed and what we learned. We learned loads from this work. Content is driven by the lived experience and the stories that were shared with us, stories of drug use and how poor poor oral health is exacerbated by drug use, but also how poor oral health can be a barrier to social reintegration and recovery, and in some cases, increased drug use to relieve dental pain. We heard about embarrassment to smile, no confidence speaking to the opposite sex, fear and anxiety of dental care, money and fines as a barrier to care. And we would never have thought of a lot of these issues ourselves or been able to understand them without this co-design and co-production approach, and to make sure that the content was appropriate to our audience, including the images that you see here, the language that we use. If you could just move to the next slide, Aileen. You'll notice that in the next slide that we have peppered these comics with evidence-based information and health promotion advice, talking about safe drugs for dental pain and tools that are evidence-based to reduce dental anxiety. And on the next slide, you'll see the front images of the other two comics that we've produced along the line, the lived experience of these people that we were working with, so through recovery and also for their family. One suggestion from this work was that we print the comics on roach paper, and this is paper that you can use to roll tobacco. The idea being that people would carry them around, actually use them, and they could form a talking point. And I presented this work to some tenured and experienced colleagues who were a bit taken aback by the thought of the roach paper, thought we were promoting tobacco use and didn't think it was a good idea. But this is where the challenge is. Unless we change how we do things and listen to what the people we are trying to serve need and how they want to interact, then we won't revolutionise healthcare. It's about immersing yourself, seeing the world from someone else's point of view, and thinking, am I really promoting tobacco use by promoting health promotion advice on a tobacco product? Or am I thinking differently about how I reach an audience I haven't reached in any other way? And that's just my thoughts for now. Thank you very much.
Thank you very much, Niall. That was very, very interesting. So I'll say last but not least, Derek Holliday, please.
Thank you, Ruth. Good evening, everyone, and hope everyone's safe and well. My name's Derek Holliday, and I'm a peer development lead with the Homeless Network Scotland. I'm also the lead research officer for CLEAR, a community lived experience action research group created in 2016. This is a partnership project between the Alliance Health and Social Care Alliance Scotland, Public Health Scotland, Strathclyde University's Centre for Health and Policy, and the Homeless Network Scotland. So CLEAR supports and promotes the use of peer research to influence change, bring about benefits to peer researchers, communities and all the relevant stakeholders. Our vision is human rights for all through our peer research, and our mission is to use peer research partnerships to positively influence human rights-based policy practice both locally and nationally. Our peer research is committed to co-developing with people, especially marginalised communities and unheard voices. So rather than for people. That is at the core to make sure that we leave a legacy behind and that we're not just going in and creating a repetitive cycle that's been created before. So it's a collective relationship of equal power that spans the entire life of the project, from proposal, invention, delivery and dissemination. So we take those participants with us on the journey once the research has been finalised, and we use that energy and that passion to take that on the road. We work with people with multiple complex needs and those with long-term trauma. This requires a model of ethos of research that focuses on social change, that promotes democracy, and it really challenges inequalities. So it does involve an iterative cycle of research, action, and also reflection. It can also help everyone gain a greater awareness of the situation in order to take that action and knowledge and confidence from the research and take that into their own lives. So the core of that is building people, strength, knowledge, and self-belief, increase the rights-based approach, empower, not disempower, and create opportunities to engage. So reversing the old age perception of service in society that we look at weakness as a self-inflicted action of our own doing, and moving from a transaction to an exchange relationship and a working partnership. So part of that core is using all this lived experience and delivering global health training in partnership with the senior health improvement officers at Public Health Scotland. And we've delivered that through dentistry, medicine, psychology, GP teaching, primary care, social care workers, nursing professionals of the future, and it's really helping bridge that experience and those that are being exposed to trauma and quite a lot of time institutional barriers. It's a collective partnership, delivering a model of excellence of peer research, that everyone's a partner in the room. There is no balance of power, everyone is equal. It's a tip of a sword. We all want positive health and positive well-being, but it's about delivering a legacy behind so that those who take part in the project continue as part of that partnership, and we create opportunities through our network and our partners to help engage them back into society, let them know that they are just as important and they are part of that society. And we do that through numerous ways: training, presentations, consultancy, raising awareness all through the country, and really helping them be part of that training and capacity building, so that we're putting that lived experience in those experts really who know the barriers and the discrimination that's in our society, and giving them a chance to speak to the next doctors and GPs and practitioners of the future, but also just to share that knowledge and insight, because not everyone works at the front line and not everyone has that in-depth knowledge of some pathways that lead people down to poor health, poor well-being, and really reduced human rights and equality. It's a unique opportunity and a unique partnership where we sit within health and university and academia and third sector, and it's really bringing all those components together to utilise all the different strengths and assets so that we can deliver really strong bits of research. We've delivered research on ACEs, on COVID-19 during the lockdown. We've delivered research with refugees, asylum seekers, EU nationals. We've delivered research on sex and sex workers and those that exchange sex, mental health, addictions, alcohol, homelessness, for those that are experiencing that. And it's really breaking that barrier that people are in trauma, so we can't speak with those individuals, we can't connect with them because we don't want to trigger that trauma. And that's a myth. Whether we have that positive intervention or not, they're going to be with that trauma. So there's a duty for us to connect with them, give them the opportunities, help them rebalance their democracy, help them rebalance their self-belief, and bring them back so that they can challenge these discrepancies and these discriminations in their day-to-day so that they can find an equal balance of life. Thank you very much.
Thank you very much, Derek. That was wonderful. Well, we now have some questions from people in the audience who are listening to us and these wonderful talks. And there seems to be a general theme, and I'd like to open this up to our experts, and that is how C19 has impacted upon people. Some of the questions have been asking specifically about people experiencing homelessness. How's it affected their oral health? And has it remained the same, or have things got worse? And I'd like to open that up to the panel, and I'd like to open up in a much broader way of how, first of all, has C19 impacted, for instance, people in prison, but also experiencing homelessness. And maybe then Niall could finish that off by saying how he, from his experience of working in NHS 5, how C19 has impacted upon services and so forth. So if I may open that up to our panel. Matt, would you like to start off?
Shall I jump in first? Because yeah, I mean,
please.
as a prison researcher in March last year, I was working for the prison service at the time. I wasn't allowed to go into prisons to do any research. No one was getting in at that point, so no one at all. So it did create a lot of challenges in research terms, and the only real way I could get around those was to write to people, because although education departments were closed and all outside agencies, family visits weren't happening, letters were still getting through, the post still worked like normal. One of the few things that kind of did carry on as it did kind of all the way through the pandemic. So I've been writing to a group of people in custody just to try and get a sense of what life is like, or what's going on in prisons in Scotland at the moment. And what I'm getting back is extremely bleak, I have to say, and challenging and concerning, to the extent that the narratives are, I'm writing to a group of long-term prisoners who are pretty used to the prison environment, but the lockdown means that they're not able to associate with any of their peers, like they're not allowed out from their cells for sometimes it's 23.5 hours a day. So they're in a pretty small cell where they're doing everything: eating, sleeping, exercising, reading, watching TV, and they weren't getting a lot of information about COVID. So obviously you can hear bits and pieces in the news, but say if you're in, let's say, Perth prison, just as an example, you might not be able to find out what's going on in and around Perth. You don't necessarily know how your family are getting on, unless it's through letters. So the people I was interviewing, they were all men. There was a lot of real apprehension around, well, that people wanted to protect and support their families. They were really worried about their families, and yet they were stuck in prison and unable to assist or ensure that they are okay, which was, I think, really distressing for a lot of people. So I've definitely heard a few people say that COVID feel, maybe we all know a little bit what it's like to be in prison, that the narratives I'm getting really paint a very different picture. It's very bleak and very challenging. So the key for me is to kind of be looking at what the transitions out of lockdown look like in prisons now. So obviously we're all getting vaccine and life's opening up for us, but what does that mean in prisons, and how does that work within the prison system where everything is still pretty shut down and people are really quite isolated? So there's lots of questions there, I think, for the prison service around how they release things safely, but it's a really difficult time in prison at the moment.
Matt, thank you very much for that. Derek, can I go to you and ask you what your experience has been with people experiencing homelessness at this time, and as you said, refugees and so forth?
Yes, certainly. I think we shouldn't be blindsided by the pandemic, because many of the challenges that those within marginalised communities are experiencing trauma or homelessness, they've had these experiences prior to the pandemic. And sadly, what the pandemic has done is heightened that and brought that really to the surface. I think we have a real challenge within our services about how we model our services and make sure those services are accessible and flexible to all communities. And when we look at psychologically informed environments, people experiencing homelessness, mental health, addictions, those marginalised communities don't find it easy to access services, and certainly within the lockdown, that's even heightened even more. But we have challenges and discrimination because people are still judged when they access those services if they present themselves. As I talked about earlier on, we look at weakness as a self-inflicted action, and that's very resident in a lot of the service cares. When we look at those that are at the front end of trauma, it's institutionalised problems that's been going back 5, 10, 15 years. So although we're seeing obviously challenges in the current climate, these are some things that have been sitting in these individuals' minds, bodies and souls for a lot longer, which has led to the point of distrust, accessing services, not believing that that service is for them. Certainly people with addictions and alcohol and going into a receptionist has been asked to disclose their entire personal life at the reception, but when they sit down, the following 5 people that don't look like them, don't smell like them, don't sound like them, are not asked the same. So we have a real challenge about education. It's not about blaming, it's about making sure that we raise that education. No one at the age of 5 wants to be an addict or suffer from mental health or experience homelessness or be on the streets or be ignored in society or receive second and third grade treatment as service. So we can't go into the habit of blaming individuals. We need to raise the noise. We need to bring more people with lived experience. They need to sit around more tables, more directors' tables, more decision making, and we need to make sure that we raise that education, because the pandemic has obviously brought it to the front, but it's been there for some of these individuals for a lot longer than the pandemic, and it will continue to be there. The pandemic is now being used as more of an additional barrier to refuse people's equality. This is why we're Scotland's moving to a right to health, human rights-based approach. That needs to be synchronised through all health services and services that promote health and well-being, so that it's your right to get health, and it's for that organisation and services to be adaptable, to be considerate. Think about people's learning, think about people's cognitive, think about travel poverty, think about data poverty, because these all come into that, as well as accessing a service and feeling it's for you, it's safe, and that you're treated as equally as everyone else.
Thank you very much. Andrea, your area is homelessness, and I wonder what your experiences have been with regard to C19.
Mm-hmm. So Ruth, what we know from our partners working directly with these groups and our contact with them as well, which is that impacted a lot. The number of people experiencing homelessness is increasing because of the pandemic scenario. People accessing services, drop-ins, food banks, they are suffering a lot. Mental health issues, depression, anxiety related with this lockdown, this social isolation, because the services, the drop-ins, they are not places, they are not just places to get food. They had a lot of support and social interaction, from the staff members. So for them, it has been very difficult not to have these services opening or opening in a reduced hours time. Regarding young people experiencing homelessness, for them as well is impacting a lot. The lack of the opportunities to go to the organizations, to attend activities coming from the organizations, to see their peers. They suffered with how can I say, the media initially, when we started the pandemic, the message that they got was that the COVID-19 was not a danger to them, to young people, just for adults and old people, so they created this image that they were not being affected, so they tended to escape the rules, the lockdown rules. So because of this, they were in risk to suffer policy visits, visits from the police, and they could be in charge, or they could be even go to prison because of this, because of breaking the rules. The consumption of alcohol and drugs as well increased among young people and adults as a way to deal with the situation. So a lot of issues impacting them and making even worse situations that before the pandemic were not good, but just became worse.
Thank you. There's a number of questions that have been really about the dental services. For instance, Sophie's been asking how to motivate people experiencing homelessness or people experiencing poverty to take advantage of free oral health services and dental programs. And I guess thinking about C19, and the question really was about what has it been for people's oral health? Has it remained the same? Has it got worse? And I wonder, Niall, from your experience in NHS5 during this time, whether you would like to say something about how the dental system is actually managed during C19.
Yes, of course, Ruth. So I think, like all healthcare, have been really impacted by the restrictions associated with COVID-19, and in particular, dental services have been hit really hard. And the issue there is around aerosol generating procedures. Whenever you go to see the dentist, basic, treatment causes an aerosol to be generated. So when the drill is used, it causes a spray, and this is possibly where COVID-19 could be transmitted. So it requires restrictions on the really heavy amount of PPE to be used, specialized PPE, which is personalized protective equipment, and ventilation and time to allow droplets in the air to drop, which reduces the amount of people that can be seen in a surgery in any one day. So immediately what you've done is you've really reduced any surgery's capacity to see the normal amount of people that they would see. So what the government did was that they reduced all care down to urgent care only, and reduced it to certain centres. So even at that point, reducing what's available on the high street, reducing where it is available, you can see that there are going to be barriers to people accessing that care. There's also a requirement to have a mobile phone to be able to phone services in advance to make appointments, and we have to think about how people access those. Reliance on digital solutions, and how people are excluded digitally and don't have access to some of these issues. So it has been difficult to provide care in certain areas and to certain groups. And so I think one of the questions as well is, what do people think about this? And I suppose I haven't really seen much qualitative work or any research done with people and asking them what they think just yet. But there are individual stories produced in the media around a delay in oral cancer diagnosis, issues with having orthodontic braces placed before the COVID pandemic and then not being able to get them seen to or removed, and having to travel a great distance for care, as I've talked about. So it's been a real compromise over the past year of what can be delivered. And one of the areas that I'm really interested in is oral cancer and the early detection of that. And we know from the data that there are clear inequalities in oral cancer, and that our most socially deprived communities experience the heaviest burden of this disease. And there's been some modelling carried out by a third sector organisation called the Swallows Group, a head and neck cancer group. And what they have modelled from data that they've picked from certain hospital units in England is that they estimate that COVID-19 will lead to a further 451 deaths associated with head and neck cancer that could have been possibly avoided. So there are clear impacts and clear potential bigger impacts on people's oral health and their lives. And within NHS 5, we're trying to understand what people do think about the services that we are providing, and this is kind of that old model of we built it and then we're going to ask them what we thought about it. But we are asking patient feedback, and we're doing some qualitative research to hopefully have answers about what we did this time round. We were, I think the country was caught on the hop. I can generally say that the government, I feel, was unprepared in terms of pandemic planning, and the NHS was definitely on the back foot for that. And the result of that will be an impact on people's general health and their oral health. I think that's as much as I can say on it, Ruth.
Thank you very much. As somebody asked about the impact of C19 on the well-being of dental professionals, and perhaps I could answer that. We've been doing some work looking at the effect of C19 with the University of St Andrews and with NHS Education Scotland. And can I just say that the effect has been, for those that felt they were better prepared, the impact of C19 didn't really result in what is known as burnout, emotional exhaustion, and leading on then to depression. So we can see even over a longer period of time, in fact, those that wish to provide a very high quality of care, it really was quite detrimental to them as COVID continued. So I think that certainly not only for people in our community, but also for dental professionals, C19 has had a major effect. Now, there have been quite a lot of questions that have been asking about projects to do with people experiencing homelessness, people in prison, and people, if you like, experiencing social exclusion, and how that relates to the dental hospital, and about free treatment. But perhaps this would be quite a good question for people to answer, in that what are projects to assist people access care who are experiencing social exclusion? Matt, from your experience of working in the prisons?
So within the prison system specifically, obviously there was a shift, really interesting shift in Scotland, and prison healthcare is delivered differently, pretty much in every country. Scotland, the delivery of all healthcare transitioned from the SBS to local health boards a few years back now, and actually the implications of that, the driving force behind that shift was that there would be equality and there would be continuity of care and services. So if I was in prison and getting dental care, that could carry on in the community, and the same with prescriptions and loads of other stuff. Apologies, there's some sirens that are going past. So the evidence on the implications of that, I haven't seen that kind of work itself through yet. So the idea is that the healthcare people receive in prison should be as good as we would expect in a community. I think that's generally true, but there are some issues there. There definitely are issues with, there's quite a lot of turnover of staff, there's a lot of locums used within prison settings, and often there's a lot of a focus on kind of handing out methadone scripts and things like that, and maybe there's perhaps not as much emphasis on kind of public health or preventative work, which is certainly the stuff I've been more interested in terms of research. So,
thank you. Derek, what would your view be on how to engage, I guess, with dentists and dental students to start to look at this whole issue of people experiencing social exclusion?
I think it's all about partnership working and moving away from the old model. So I think we all collectively need to work as one body. So better, stronger relationships with third sector, looking at pathways for people that are marginalised and those that are experiencing homelessness and addictions. So stronger partnerships with pharmacies is one of the main places where people have their interaction to pick up their methadone, better interaction with prisons, better education in schools, and certainly looking to have placements across a lot of the homeless and health sector so that people can go and visit locally. For quite a lot of people, the main barrier is travel. They're picking between food and travel, picking between food and access to the internet to find that support and services. So I think it's moving out of the kind of silos that quite a lot of the health services initially worked in, and start to spread it in the community, because the stronger we are, the greater we use our assets. We provide health and support in this country from a reactive position. I think we need to be more proactive on that. We know we're human rights when they're being impacted. We go to the dentist when we're in our worst condition. We go to the doctor when we're in our worst condition. But as a preventative model, by bringing that education and awareness in a lot earlier and thinking of the pathways where people go all the time for these marginalised communities, health services, support services, AA addictions, prison services, pharmacies, and having multiple diverse staff, so a kind of more wider net within the community, so we can pick people up a lot earlier. So if you've got someone trained in a pharmacy who has the experience of knowing and being able to look for kind of mouth cancers as now described, these are some of the best people to have a relationship with those who are struggling with addictions. It's that person within the pharmacy is the strongest person to be able to connect them with a service, provide information, or do that initial check as a first stage triage to then use that relationship to move them on, as opposed to when you are struggling, then you're not in a thriving mode, so you're not able to make conscious, clear decisions. You're in survival mode, and it's either your addiction or somewhere to stay or your health or trying to find some food or gas or travel money. So it's trying to create an equal balance and find out where that individual person has their strongest relationships in their support care plan, and really to utilise that and connect that in with dentistry and other parts of their health to promote that well-being, as opposed to it always being levied on the individual when they're actually at the worst part of their life to make a conscious decision to pick between these life deciding options in their day-to-day. Their world becomes a lot smaller. So it's understanding those relationships and their pathways and really connecting that dentistry and those support services along that pathway so we can build that continuity of care, so the leap isn't as much because they've got reliance on those strong relationships and the people they see every day. And for me, pharmacies are one of the main places where we're looking at, obviously, a lot of the damage is done through people through teeth, through addictions.
So if I take you up right then, Derek, what you're saying is that any project which has got to do with people experiencing social exclusion has to be partnership working, not just dentists working on their own, yes, but working, as you say, with people, pharmacists, doctors, chiropodists, and in particular people with lived experience of homelessness, for yes, instance, or refugees.
I think the pandemic has shown us that we live in a world now, there's so many multiple complex needs that our health services and the responses cannot be silos anymore. We need multidisciplinary services, that you don't have to go to your dentist here, then go to your doctor, then go here for your addictions, then go here for your therapy, go here for psychology, go here for chiropodists. That when we're building and delivering new healthcare going forward, that if we put all these in the one building, then we have the opportunity to have someone go for a day and deal with 3 or 4 key things that promote positive health and well-being, rebuild the relationships that have been broke over the past 5, 10, 15 years has led to this distrust, and be able to capture the moment, as opposed to expecting someone who's in trauma and in total survive mode to make 6 or 7, 8 journeys just to achieve a really basic standard of good health and well-being. So it's like a web. And I think all these services all work together to promote health and well-being, and we need to connect them. It's not homelessness responsibility, it's not addictions, it's not dentistry, it's not mental health. They all should be connected, because what they all promote is what we're all wanting, is strong, healthy people managing their own lives, not their lives being managed for them, and having confidence in accessing good quality health and well-being without it feeling like a marathon and so many barriers that we don't think about in our normal day-to-day.
Thank you. And I suppose what came into my mind then, following on from what Derek was saying, was that I'm thinking about now Andrea and Niall, both in the dental school. And the question really is about how can we make sure that dentistry is part of this network that Derek was referring to. How can we start to connect and, I suppose, enable our students to be able to connect with people who are experiencing social exclusion? Andrea. Andrea, I think your microphone might be off. We can go to Niall. Niall, what are your thoughts about how to engage the students? How could we make the dental school more accessible is the question.
Yeah, I think it's a good question. I think we've tried to, well, there is a start to involve students and change their thinking towards this holistic approach to the patient that's in front of them, to think beyond the mouth, to think beyond that tooth that is broken down and what you're going to do about that. But think about the person and what it is that they're really there for, and how you can best help them. And I think one of the examples of some good work within the dental school is the project in the 4th year BDS program, where the students do some outreach work to groups within Dundee City. So for example, they've engaged recently with the Scottish Drugs Forum and the trainee addiction workers there to understand better about what people who have lived experience of drugs and alcohol, what their oral health needs might be, what they might expect when they go to the dentist, and how they can best be helped when they're at the dentist as well. And I think it's exposing our students to these activities as they train, and letting them step back from the drills and all the injections and everything, and look at that person and think of the holistic approach. It also requires us to break down the silos within the university also, and to look out beyond the dental school. So we have the medical school, and we have the School of Humanities, the School of Business, and all sorts. So it's how do we integrate those students and to get them to look beyond the walls of the dental tower as well, to think more broadly about how they provide healthcare and what the dentists of tomorrow will be. So I think we've kind of started that journey. There's a bit more work to be done. And all of these conversations are great. I think what Derek had to say about the multidisciplinary team working is absolutely fantastic, and I think that is one of the keys, and that has to be embedded in the education of our healthcare professionals of tomorrow to make it really happen.
Thank you very much. Now, Andrea, is your microphone working now?
Yes.
Good. So
Sorry,
over to you.
It was slow. It's taking too long to unmute. Yeah, I totally agree with Niall. I think it's our duty to create more opportunities for students to connect with other schools and to connect with the community. So in dental school, we have this community projects that 4-year students, they have to develop outside university with organizations from different areas of knowledge. So this is something very valuable for their experience. But we need to do this more regarding teaching and research practice. We need to include staff members, colleagues from different disciplines looking at the same subject, because this is the way that we can learn from other fields of knowledge, and we can amplify our way of teaching and way of doing research.
Thank you very much. Matt, I'm going to actually come back to you and put you on the spot, okay? Because sometimes I think it feels, especially as a dental public health person, you know, other schools think, well, what's teeth got to do with it? And so I think that certainly we feel that this multidisciplinary approach is really so important. How can the School of Social Work and Education help us in dentistry to push things forward?
It's a really good question. And I don't know about anyone else, but I'm sure I've been part of conversations like this for years and years. The classic is health and social care, and those two worlds kind of collide and never seem to kind of be able to find ways to collaborate, which is always coming up in these sorts of conversations. So in relation to, say, my students, I'm encouraging them to link criminal justice and research in relation to prisons, to questions of social justice more widely. I think certainly me, colleagues that I work with in education and social work, say Fernando, who does a lot of amazing work on prisons, I think we can offer a lot in terms of methodologies, probably kind of different sort of sociological insights into the prison system, the prison world. I'm an anthropologist. My PhD, I lived in a village in Nepal. Now I'm trying to find ways to adapt my methods to understand what's happening in prisons in a meaningful, kind of rich way, and it is really challenging, but I think those insights can be useful for colleagues in the dental school and other places. So I guess it's a commitment to social justice, but it's also the insights that we can bring through our different methodologies, through our different kind of approaches, our different epistemological approaches. I think that with the right kind of openness, I think that could be a real beneficial, I don't know, it could complement what you're doing and work alongside. I think you could see that in some of the work that you've done in prisons, Ruth. So one of the points was about kind of equality within the prison system, and you can look at, I'm really interested in culture, so you can't just assume that you're going to go into a prison system with a really great intervention and then it's going to get picked up, and you've got to understand the context, you've got to understand the culture within which you're trying to operate. And that's the sort of thing, certainly I as an anthropologist, I'd like to think I'd be able to contribute those insights.
Well, you know, perhaps Matt, quite appropriate, because you're now you can run if you like, but you won't be able to hide. We're going to get you involved one way or the other.
Sounds great.
Good. So, right at the very, very first question that somebody asked was, is this session about dental care? Well, yes, it is about dental care, very much. It is about how we understand the individual who is living in their world, living in our society, and what their dental health needs are. As I always think that the mouth is sort of, we can see inequality when someone opens their mouths. And then we understand what sort of foods they're able to eat. Are they able to afford a toothbrush and toothpaste? So everything we've talked about today during this event is very much about how, if by understanding oral health and broken smiles, we can then talk to people, understand it from their perspective, work in a multidisciplinary way to then really revolutionize healthcare, often using oral health as an example. Now, I see our time is nearly up, and I'd like to thank everybody. But one of the last questions that came up was, what are the opportunities for students to be involved in this work? And I know from my own work, and I know from what Matt's been saying and Andrea, that we very much would like students to be involved in this work. So I think it's just for me to say thank you very much for participating in this event this evening. As I said, it will be online in a number of weeks. I'd like to thank our four speakers, Matt Mayock, Andrea Rodriguez, Niall McGoldrick, and Derek Holliday for their fascinating insights into the area of society, social justice, and how we can move things forward and revolutionize. And I think, just to finish off what Matt said, not only healthcare, but also social care. And finally, apart from thanking yourselves for taking part on such a lovely evening, coming to listen to us, I'd like to thank the University of Dundee team, Peter Murray, Emma Beat, and Aileen Ross. So thank you very much, and I hope you all have a very good Easter Sunday. Bye-bye.